Welcome to the Deep Dive. Today we're tackling Burkitt's lymphoma, a really important topic for your revision.
Absolutely.
We've got a wealth of information here, and our aim is, to really pull out the crucial bits so you walk away with a clear, concise, hopefully memorable understanding of this, well, aggressive non-Hodgkin lymphoma.
Exactly. We'll be looking at what defines it, what causes it, who's at higher risk, how it tends to show up,
Right.
and then cover diagnosis, treatment, and the overall prognosis. Think of it as kind of turbocharging your Burkitt's revision.
Okay, perfect. Let's dive right in. Burkitt's lymphoma, what exactly are we talking about?
So at its heart, it's a type of non-Hodgkin lymphoma, highly aggressive. And it's characterized by the rapid, uncontrolled growth of abnormal B cells.
Okay, B cells, those immune cells.
Right, the ones crucial for our immune response. And it gets its name from Dennis Burkitt, who first described it. It's often linked quite strongly, actually, to the Epstein-Barr Virus, EBV.
Aggressive and rapid growth. Those seem like the key takeaways there. And you mentioned types. There are different kinds.
Yes, that's right. Three main ones. First, you've got the endemic form. You mainly see this in equatorial Africa, mostly affecting children.
Right, Africa, kids.
And this type has strong links to both malaria and EBV. It commonly involves the jaw and abdominal organs.
Okay.
Second, there's the sporadic form. This occurs outside Africa. It's less consistently linked with EBV, and it often shows up in the ileocecal region.
So part of the bowel.
Yeah, exactly. Then finally, there's the immunodeficiency-associated form. As the name suggests, really it occurs in people with weakened immune systems.
Like HIV or people on certain drugs.
Precisely. HIV or immunosuppressants. So you can see there's this interplay, isn't there? Geography, co-infections like malaria, immune status. It all affects how it presents.
That's a really helpful way to think about it. Endemic Africa, kids, jaw, sporadic elsewhere, gut focus, immunodeficiency linked to weak immunity.
Right.
Okay, so what actually causes it? What's the etiology?
Well, EBV is a big player, definitely, especially in that endemic form we talked about. But the sort of fundamental underlying cause across all types is a specific genetic change, the translocation of the MYC gene.
The MYC gene. Okay, tell us a bit more about that. That sounds pretty crucial.
It really is. The MYC gene sits on chromosome 8. Normally, it's what we call a proto-oncogene, basically. It helps regulate cell growth and division, keeps things in check.
Right, a normal job.
Exactly. But in Burkitt's lymphoma, this gene gets moved, translocated, usually to a spot near an immunoglobulin gene on chromosome 14. Now, immunoglobulin genes are super active, right? They're making antibodies all the time.
Yeah.
So this move puts the MYC gene under the control of this really powerful on switch from the immunoglobulin gene. And that leads to massive overexpression of MYC. It's like the accelerator pedal for cell growth gets jammed down.
Ah, okay, so it's in the wrong place, getting the wrong signals, leading to this uncontrolled B cell growth.
That's it in a nutshell.
So that genetic mishap is central. What else puts someone at higher risk? You mentioned EBV.
Yes, EBV infection is a major risk factor, really bumps up the risk, especially for endemic Burkitt's.
Okay.
Then, a compromised immune system, like in HIV/AIDS, is a clear risk for the immunodeficiency-associated type.
Makes sense.
And in those endemic regions, malaria seems important too. It might weaken the immune system or maybe stimulate B cells somehow. We're not entirely sure of the exact mechanism.
Right.
And like with many cancers, there could be some genetic predisposition, maybe a family history of lymphoma, but that's less clearly defined for Burkitt's specifically.
So EBV, weakened immunity, malaria in certain areas, maybe some genetics.
Got it. We've talked about the MYC gene translocation causing this overdrive. Can we delve just a bit deeper into the pathophysiology? What's happening at the cellular level?
Sure. So when MYC is overexpressed, it doesn't just make B cells divide like crazy. It also messes with apoptosis.
Programmed cell death. Exactly. The normal process where cells die off when they're supposed to. So these abnormal B cells are multiplying rapidly and they're not dying off.
A double whammy.
Pretty much. And that leads to this huge buildup of rogue B cells, forming those rapidly growing tumors that are just so characteristic of Burkitt's.
Right.
And these tumors can pop up in lymph nodes or other lymphoid tissues, depending on the subtype.
Okay, so more proliferation, less death equals aggressive tumors. Makes sense. Now, if a clinician suspects Burkitt's, what else might be on their mind? What's in the differential diagnosis?
Ah, good question. Really important. Because it grows so fast and has certain features, you absolutely have to rule out other things. Diffuse large B-cell lymphoma, DLBCL, it's a key one. Another aggressive B-cell lymphoma, lymphoblastic lymphoma, often involves T cells, can present in younger people too, so that needs consideration.
Right.
And then, other types of non-Hodgkin lymphomas, even some T-cell lymphomas could potentially look similar initially. So you really need that biopsy. Pathological examination is essential to nail the diagnosis.
So it's not always obvious just from the clinical picture. Need that tissue diagnosis. Let's zoom out again, epidemiology. How common is Burkitt's, say, in the UK compared to globally?
In the UK, it's relatively rare, a small slice of the non-Hodgkin lymphoma pie. You might see it a bit more in people with links to those higher incidence regions, like sub-Saharan Africa, tying back to the endemic form and EBV.
Okay.
Globally, it's different. It tends to affect children more often. Peak age, around 6 years old, represents maybe 1 to 5% of all non-Hodgkin lymphomas worldwide.
And more common in boys.
Yeah, significantly. About a 3 or 4 to 1 male to female ratio. And as we've said, it's a major childhood cancer in sub-Saharan Africa. You also see higher rates in places like South America, North Africa, the Middle East, Papua New Guinea.
Wow.
And the common factors across these places, strong links to EBV and that MYC translocation. Plus, cofactors like malaria, maybe other viruses could be playing a role too in certain areas.
So, uncommon here, but a huge issue elsewhere, especially for kids. And EBV and MYC are the recurring themes. Okay, how does it actually look? What are the clinical features that should make you think Burkitt's?
The classic sign is a rapidly growing mass. A lymphoid tumor growing quickly. Patients might notice swelling, often jaw or facial bones developing really fast, or maybe abdominal pain from a mass inside.
Right, that rapid growth again.
Exactly. And the B symptoms are common too.
Fever, night sweats, weight loss.
Yep, those three. Plus general fatigue, feeling unwell, malaise, that kind of thing.
Okay, fast-growing mass, maybe jaw or belly, plus those systemic B symptoms. Does it present differently depending on the type?
It often does, yeah. The endemic form frequently hits the maxilla or mandible, the jaw bones. That leads to that really noticeable, rapidly increasing jaw swelling. And the speed is just incredible. Sometimes the tumor can double in size in like 18 hours.
18 hours. That's incredibly fast.
It really is. They might also have rapidly enlarging neck and jaw lymph nodes.
Okay. And sporadic.
Sporadic tends to involve abdominal organs more often. Things like the ileum, caecum, mesentery. So it might present as an abdominal mass you can feel, maybe fluid buildup called ascites, pain, or even bowel obstruction.
Right.
B symptoms are common in both, remember. And the HIV-associated type often looks more like the sporadic form in terms of where it shows up. The key things are just how aggressive it is and these different patterns based on the subtype.
That rapid growth in the endemic form really hits home how urgent this is. Okay, so if you see these features, what investigations get done?
Well, the absolute cornerstone is a biopsy. You need tissue. Get a sample of the affected area for histology. Look at it under the microscope.
Right.
Immunophenotyping is also crucial. That identifies specific proteins, markers on the lymphoma cells to confirm it's B-cell and specifically Burkitt's.
Okay.
Then imaging. CT scans, PET scans vital for staging, figuring out how widespread it is, where else it might be, and often a bone marrow biopsy too to check if it's spread to the bone marrow.
And under the microscope, what are the pathologists looking for?
The classic finding is the starry sky appearance. It's quite distinctive.
Starry sky.
Yeah. You see this dense sheet of the blue lymphoma cells, the B cells, and scattered among them are these larger, paler cells, macrophages. These macrophages have eaten up bits of dead tumor cells. So you get these pale stars scattered across a dark sky of lymphocytes.
That's a very vivid image. Easy to remember. You mentioned staging with the scans. Can you briefly outline how Burkitt's is staged?
Sure. We usually use the St. Jude modification of the Ann Arbor system. Stage 1 is basically a single tumor or just localized lymph nodes.
Okay.
Stage 2 might be a single tumor with nearby lymph nodes involved. There's a specific Stage 2R for abdominal disease that's been completely surgically removed.
Right.
Stage 3 is more widespread tumors on both sides of the diaphragm, maybe chest involvement, spinal cord, or extensive abdominal disease. And that gets split into 3A for non-surgical abdominal disease and 3B for multiple abdominal sites.
Okay, getting more advanced.
And then Stage 4 means any of the above, but with involvement of the central nervous system, the CNS or the bone marrow when it's first diagnosed.
Got it. A clear system to define the extent. So, moving on to management. How is Burkitt's treated, say, in the UK?
The main approach, the absolute mainstay, is intensive chemotherapy, often high-dose regimens.
Intensive chemo.
Yeah. Radiation might have a role sometimes in specific situations, but chemo is central. And because this is so aggressive and because of risks like tumor lysis syndrome, you really need specialized oncology teams managing this.
Right. What do these intensive chemo regimens typically involve?
Well, the good news, despite how aggressive it is that Burkitt's is usually highly sensitive to chemotherapy. So we use combination regimens, multiple drugs together. Things like cyclophosphamide, vincristine, doxorubicin are common components.
Okay.
And because there's a real risk of it spreading to the CNS, prophylaxis is crucial. That means giving intrathecal chemotherapy, injecting chemo directly into the spinal fluid to prevent or treat CNS involvement.
Right. Protect the brain and spine.
Exactly, and sometimes rituximab might be added. That's a
Yes.
monoclonal antibody targeting D cells, can make the chemo work even better.
You mentioned tumor lysis syndrome, TLS, as a risk. That sounds serious. How is that managed?
It is serious. Basically, when the chemo kills lots of tumor cells very quickly, all the stuff inside them gets released into the blood.
Like electrolytes, uric acid.
Precisely. High potassium, high phosphate, low calcium, high uric acid. It can overwhelm the kidneys, cause dangerous heart rhythms. It's a metabolic emergency.
Wow. So what do you do?
Management is key. Lots of intravenous fluids hydration is critical to help the kidneys flush everything out. Drugs like allopurinol or sometimes rasburicase to lower uric acid levels, maybe making the urine more alkaline, and very, very close monitoring of electrolytes and kidney function.
If that's not enough.
In severe cases, patients might need dialysis to support their kidneys.
Okay, so TLS management is a huge part of the initial treatment. Are there other treatment options beyond chemo?
Well, if the lymphoma comes back relapses or if it's very extensive initially, a stem cell transplant or bone marrow transplant might be an option.
How does that work?
It involves giving even higher doses of chemo, sometimes with radiation too, to wipe out any remaining lymphoma and then giving back healthy stem cells, either the patient's own collected earlier or from a donor to rebuild their blood and immune system.
Intense.
Very intense. Surgery has a limited role, maybe to relieve a bowel obstruction caused by a tumor or sometimes to remove a small localized abdominal tumor before chemo.
Okay.
And interestingly, in resource-limited settings for endemic Burkitt's, sometimes less intensive chemo regimens, maybe just using cyclophosphamide and methotrexate, can still have some success, although outcomes aren't usually as good as with the intensive protocols.
Right, adapting to the context. So after all this intensive treatment, what's the outlook? What's the prognosis like generally?
It really depends. Stage is a big factor, obviously. Patients' age, their general health, and crucially, how well the lymphoma responds to that first round of treatment.
Makes sense.
For patients who have localized disease, stage 1 or 2, the survival rates are actually very high now, often over 90%.
That's fantastic considering how aggressive it is.
It really is. Even with more advanced disease, those intensive chemo regimens have massively improved things. 5-year survival rates are often quoted in the range of 75 to 85% in many studies.
Still very good.
Yes, but the prognosis is usually poorer if there's CNS involvement or if the patient has coexisting AIDS. And very rarely, Burkitt's can transform into something more like leukemia, which also affects the outlook.
Okay, so aggressive but highly treatable for many, especially if caught and treated effectively. We've touched on TLS. What other complications might you see with Burkitt's or its treatment?
Yeah, several things. Infection is a big risk. The disease itself weakens the immune system and the chemo knocks it down further.
Right.
Then you have the direct side effects of chemonausea, vomiting, hair loss that increased susceptibility to infection again.
Standard chemo side effects.
Pretty much. And long term, there's always a small risk of developing secondary cancers years down the line because of the treatment. And we already mentioned bowel obstruction and TLS as more immediate potential complications.
Okay, lots to manage. Now, thinking about revision, this is a lot to take in. Any useful memory tips or mnemonics? Maybe some example questions.
Yeah, definitely. For the 3 types, try thinking eat some ice cream, endemic, sporadic, immunodeficiency.
Eat some ice cream. Okay, I like it.
And link endemic to African malaria jaw, sporadic to elsewhere gut, immunodeficiency to HIV weak immunity.
Got it.
For that key MYC gene translocation, just try to lock in the numbers 8 and 14, chromosomes 8 and 14.
Okay, so 14, simple enough.
And the starry sky, just picture it, a dark night sky, lots of blue cells with those bright macrophages scattered like stars.
Nice visual. How about some quick fire questions?
Okay. A 6-year-old child from, say, Uganda presents with rapid swelling of the jaw. Which type of Burkitt's lymphoma is most likely?
That would be endemic.
Perfect. Another one. What's the key genetic abnormality consistently found in Burkitt's lymphoma?
That MYC gene translocation between 8 and 14.
You got it. Oh, and for remembering B symptoms, fever, night sweats, weight loss, maybe think bad news world.
Okay. Bad news world. Fever, night sweats, weight loss. I'll remember that.
Whatever works.
Excellent tips.
Yeah.
And just to stress again that rapid growth seems absolutely critical to recognize. Needs urgent attention.
Absolutely critical. Time is of the essence with Burkitt's.
Well, that pretty much brings us to the end of our deep dive into Burkitt's lymphoma. We've covered, well, a lot of ground.
Yeah, definition, types, the genetics with MYC, risk factors, how it looks clinically, investigations, that starry sky.
Management, prognosis, complications. This works.
Our aim was really to give you a clear, high-yield overview to help with your revision. We hope it's been useful. Of course, always go back to your main textbooks and resources for the full picture.
Definitely. And if you are looking for more great resources for your MSRA prep, do check out passthemsra.com and also freemsra.com.
They've got some really useful stuff there.
Absolutely.
And maybe a final thought. Just reflecting on how far treatment has come for such an aggressive lymphoma, the progress in chemo and understanding the biology really has changed the outlook dramatically for many patients.
A really positive note to end on. Thanks for joining us for this deep dive.